and sent me that the program only talk about the DVT, deep vein thrombosis. So I only prepare for DVT diagnosis. Actually, okay. You know that we have some terminology for this kind of disease. You know, the DVT is deep vein thrombosis. That is the thrombus from in the deep vein, and then if this thrombus move, it can come an embolus, and it when it comes to the heart and then come to the pulmonary artery, it can block the pulmonary artery, and we have the term pulmonary embolism. That is a PE. So that is a kind of disease. So we call the DVT and PE are the venous thromboembolism or VTE. So today I talk about the DVT in the ICU. So you know that in the ICU context, the risk for patients that have the thrombus, the DVT, also higher, much higher from than other patient, because of ICU patient possess multiple components of the vital triad. We know that the vital triad include the endothelial injury, venous stasis, and hypercoagulability. In the ICU patient, the central venous catheterization and trauma make the endothelial injury more common. So that is the one of the risks for the thrombus DVT. Next, the venous stasis, when patients have prolonged immobilization and mechanical ventilation that increase intratoracic pressure. So the venous stasis is not well. So patients have also more risk for the thrombus, and also when the patient in critical ill with systemic inflammation, sepsis, and surgical stress that make the hypercoagulability state. So all of these things that make the patient in ICU always have the high risk for DVT than other patient. So, and also we can note that the classic clinical sign, for example, the erythema, swelling, are not notorious, unreliable because of it masked by general edema or sedation state of the patient. So when the patient have some symptoms that suggest for DVT, we can assess for the score that this is well score for risk classification for DVT. That it has 10 components, and with one of the first to 9 components, we give the patient 1 point, and last we minus 2 points. If the patient have above 2 points, so that the patient have the probability of DVT with 28%. That we have to do the ultrasound, do the test, the D-dimer test for the patient that to confirm the patient have DVT or not. So the component of well score includes that patient has paralysis, or recent orthopedic casting of lower extremity. That's 1 point. Patient have bedridden over 3 days recently or major surgery within past 12 weeks. Patient have localized tenderness of the deep vein. The patient have the swelling of entire one leg, or patient have the calf swelling 3 centimeters greater than other leg. That must measure 10 centimeters below the tuberosity. The next component is the pitting edema greater in the symptomatic legs, or non-varicose collateral superficial vein. Patient have active cancer or cancer treated within 6 months. Patient have previous documented DVT that we give 1 point for one component. And if patient have alternative diagnosis, at least as likely as DVT, for example, Baker cyst, cellulitis, muscle damage, superficial vein thrombosis, or post-thrombotic syndrome, inguinal lymphadenopathy, extreme venous compression that we minus 2 points from the score. So in the ICU, we know that patient, almost the patient have a mechanical ventilation or sedated patient, so they will be bedridden or immobilized. So that score for the well score or always higher. So that the DVT likely almost have in all patients. So in all patients in the ICU that for need treat for the long prolonged, so we have to consider that patient have DVT likely. So the next thing that after assess the well score is we do the testing, the D-dimer test. It is degradation product of cross-linked fibrin. So it's highly sensitive, that approaching 95 to 99%, but it has poorly specific for the diagnosis but positive DVT. So its application in the ICU that all the patients almost have elevated D-dimer because of acute phase responses. For example, recent surgery, trauma, sepsis, or AKI that make the level of D-dimer elevated. So in the role of D-dimer is to rule out or that patient if have not likely DVT and of well score, and then the D-dimer test negative, that we can rule out the DVT in that patient. And then we move to if the patient have a D-dimer positive, we have to do the compression ultrasound. So that is the diagnostic imaging. We know that the biochar compression ultrasound is the diagnostic of choice because of its portability. It's very safe, and the patient have not exposed to the radiation or contrast requirement. But it is not the perfect test because of the sensitivity of ultrasound only approach 90%. It depends on the operator experience. It depends on the location of occlusion, like if the thrombus in the calf vein, that is more difficult to see than other position. It depends on the age of occlusion or the degree of occlusion, and it also depends on the visualization of the patient. That if the fat patient, big legs, so that for or the patient has the edema leg that make the visualization cannot be sure. So we can have to consider the predict probability of ultrasounds. Move to the anatomy of DVT location. So this is the figure that see that 10% of the patient have isolated popliteal thrombus. 42% patient have the thrombus in popliteal and femoral vein. 5 to 8% that patient have the position of the DVT in popliteal femoral vein, common femoral veins, or in IPC or iliac vein. So 5.5% of patients have isolated FV. So and 35% of all DVT involve the proximal vein. So all the DVT mostly involve the CFV or popliteal veins. So the ultrasound sensitivity for this finding is the 85 to 90%. So if we do the ultrasound that we compress, we have compressed ultrasound in the Stephanos position and popliteal position, we can find almost the 95% of the patient who have DVT, but we can note that the isolated clot in FV does occur. So if the patient had only isolated DVT in FV, and we do the compression bedside ultrasound not only in the Stephanos position and popliteal position, that we cannot find the DVT. So we have two methods for assessing the DVT with bedside ultrasound. We can do the 2-point compression or 3-point compression. The 2-point compression that we can do the ultrasound in the CFV in the Stephanos position, and the second position is in a popliteal veins. The 3-point compression also have the CFV and the position that bifurcation of DVT and FV. SFV is the name before, superficial femoral vein. Now we call it the femoral vein. And the last position is the popliteal vein followed to bifurcation. So with the 2-point compression have the sensitivity of 85.76% and the specificity with 98.5%. And the 3-point compression have a sensitivity of 90.5% and the specificity of 98.5%. And also we have that isolated FV clot do occur. So if we do the 3-point compression, it can increase the sensitivity for finding DVT in the patient. So what is the finding that we have? We can see if we use ultrasound that they have the three main symptom finding that the first is the non-compressible vein, and the second is the intraluminal echogenic material, and the last one is the decreased response to augmentation. If the patient, firstly, we have the non-compressible vein, that the wall of the vein failed to completely oppose with compression. So we apply a compression to the position, and then we see that the vein cannot move to oppose together. So we can see, we can also think that this have a thrombosis inside. And the second finding is the hyperechogenic material inside the vein. You can see that inside the vein we have some material that hyperechogenic. So that may be the thrombosis. And if we switch to longitudinal view, we can see that the thrombus can have one side thrombus. And the last finding is we can see the decreased augmentation in the vein, that we can apply pressure below the vein. Normally the vein will have that apply the pressure that the vein will bigger because of the we compress that it's much more pressure, so the vein can be bigger. But if we apply pressure below the vein, that but the vein will also remain, that we can see that maybe it is a thrombus inside. So it is a summary for the finding that the primary diagnostic criteria for DVT is non-convexity, and the secondary criteria is echogenic thrombus or loss of augmentation. And this is a clinical algorithm that patient have a probability that DVT likely or unlikely, set with Welsh score. So if patient have a DVT unlikely, we do the D-dimer test, and if it is negative, so we can sure that the patient have no DVT. If the D-dimer test positive, we can do the compression ultrasound, and if it is negative, that patient have no DVT, and if the patient have positive ultrasound finding, that we can accept that patient have DVT, and then we have to treat the DVT. If the clinical probability that DVT likely, we also we can do the ultrasound, and then we find for if the patient have a positive ultrasound, so we treat the DVT. We cannot do don't have to do the D-dimer test. But if the ultrasound that negative, so we assess the D-dimer. If the D-dimer is negative, so it's no DVT. So we can assess the risk for DVT and have DVT prevention. But if the D-dimer is positive, we have to repeat ultrasound normally after 1 week, and also we have to assess the risk for DVT, and we have to do the prognosis for the DVT. So the next speaker will talk is for this. So it's all the thing I want to share with you. Thanks for your attention.
Yeah, thank you very much, Dr. Chung Anh, for the talk. And I think that you have a lot of update in which I learned from what we talk in the literatures, and in my textbook, I feel like I still need to update from you. So what we know about that is in the IEC patient, we have very high risk for DVT or PE or VTE. That's what it's very difficult to make a diagnosis, because those patients is very severe patient, and they have so many risk factors for that. And you focus in the risk scoring system, in which Welsh score is still very popular in Vietnam. I know the boss is one of the champion and one of the expert in the how to apply the Welsh score and to make a diagnosis of PE. D-dimer is what is very popular in many ED and ICU, and I think that unfortunately it's working for the rule out more than rule in. And you talk about this very update today for me, that is how to analyze ultrasound results, and by doing with compression and something like that. Sometimes it's not easy for me to understand because I'm not the expert in the ultrasound. However, nowadays I'm working as a president of the Vietnam Society of Point Care Ultrasound. So I hope that I learn from you, and I learn from you guys, and in the future, then we can work together in make a ultrasound for emergency medicine become very popular in Vietnam. So next, we would like to introduce next speaker. he working for Cardinal Health. I guess it's a very big organization in Singapore. And Dr. Nicholas Cho. So we can introduce more about ourselves. And the topic of Dr. Cho today is venous thromboembolism prophylaxis. So please welcome him. Dr. Cho?
Thanks a lot, Dr. Sung. Are you able to see my screen?
Yes.
Is it good?
So,
Perfect.
yeah, you look good, but
Okay,
you
great.
make it bigger.
Okay.
Okay. It's good.
All
So,
right. Thanks a lot, everybody. First of all, good evening, everyone. Thanks, Dr. Sung, for the brief introduction. It's a pleasure to meet you. I hope one day I'll be able to see you in person as well. So once again, a very good evening, everyone. And thanks to the previous speaker for the wonderful presentation as well. So without further ado, I think because there are time limitations and I know how busy the ICU is, so I'll try to make every minute count. A little bit about myself. So I'm Nicholas. I'm based out of Singapore. I'm a clinician by training. My last practice was with ONG. So I'm an ONG doctor. And then after that, now I'm with Cardinal Health, heading the medical affairs for the APAC region as well. So today, what I want to talk to everyone about is basically similar. It's more about VTE, and then of course, something that lands on your doorstep every shift, VTE in your critically ill patients, and where IPC or intermittent pneumatic compression sits in your prophylaxis strategy. So we'll move through the evidence, and then after that, what happens is more like a peer-reviewed papers and what's the current clinical care practices says as well. So this is just a disclaimer. So I'm currently working for Cardinal Health, just for everyone's knowledge, basically. So here's how we are structured today. We'll start off with ICU specific VTE picture, the numbers that basically live in your unit specifically. 3 clinical papers, the CACOS 2022 Cochrane Review, IPC Super Randomized Control Trial, and Ho and Tan meta-analysis from Circulation. So basically all these are quite powerful papers basically. After that, we'll go what major ICU guidelines say, and then I'll try to close the day with some of the takeaways that maybe you can apply subsequently, or something that you can take away to your wards. So let me, in this slide, right, let me anchor us on the numbers that actually matters most specifically in this room today, which is the one on the bottom right, basically the number. So in the ICU, VTE occurs in 4 to 15% of patients admitted to ICU. So despite routine pharmacological prophylaxis, so it means that not patients without no protection or patients with no protection. It's more like patients are already on heparin. So that's the problem. And in wider context, what I'm going to say is that VTE affects 10 million people globally per year. PE accounts for 10% of all deaths. Up to 50% of survivor, both PE and DVT, basically carry long-term functional impairment. And of course, thromboprophylaxis reduces that risk by up to 60%. So what I'm trying to say that this is a preventable issue. And across all specialties, different specialties, we have orthopedic surgery, basically 23 to 60% of VTE incidents, up to 25% in DVT in neurosurgery. And then after that, of course, the gynae onco side, basically, you have 3 to 4% in cervical, 4 to 9% in endometrial, and 70 to 38% in ovarian cancer. Now, the real burden is across the hospital, of course, but for everyone in this room, the ICU figures is what drives that follows. So why are ICU patients such having disproportionate risk, basically higher risk? 4 factors that basically converge almost universally in critical illness. So first of all, sedation, where your patients aren't moving, so venous stasis sets in immediately. Vasopressors, so direct endothelial injury, altered venous tone, immobilization days to weeks without any limb activity, and of course, also central venous catheters, so direct endothelial trauma, structural site for thrombus. So that's the Verkaus trial I was explained earlier. I wouldn't talk much about it, but it is why VTE prophylaxis in ICU is such an important thing, and we'll see why as we go along. So in this slide here that we can see, right, Sally and colleagues actually published this thrombosis journal in 2023, so it's a relatively new journal, a retrospective analysis of 1.4 million ICU admissions basically across Australia, New Zealand, hospitals from 2009 to 2020. So their finding basically is very simple. It's omission of VT prophylaxis within the first 24 hours after ICU admission without a documented contraindication or clinical reason was basically independently associated with 35% increase in odds of in-hospital mortality. So from 1.4 million admissions, that's basically not a very weak signal. It signifies that, basically it's a very important thing that we need to take note of. And the critical nuance that the authors actually called out explicitly in patients with head trauma, subaortic hemorrhage, basically, the mortality association was not observed, which makes clinical sense because given the bleeding implications in those patients. But for your medical and general surgical ICU patients without documented reasons to withhold prophylaxis, the data basically says delayed thromboprophylaxis independently kills people. So the practical implications is pretty simple. Prophylaxis conversation needs to happen as early as possible, basically. And let's go into the clinical evidence, basically, starting with the most comprehensive systemic review in this space that we have. The CACOS 2022 Cochrane is basically the gold standard here. So it's the third update of a review that actually began in 2008, comprising 34 studies, 15,000 patients. And then after that, in 2008, basically, it was 11 studies and 7,400 patients only. And by 2022 update, we get the 34 studies and 15,000 patients. So that trajectory actually matters because with every update, the sample size grown and the findings have held consistent. So the specialties basically go across the board from ortho, uro, neuro, general surgery, ONG, trauma, and of course the medical patients including ICU. So all across the board, all specialties were actually included. And this is basically the evolution of the evidence that I mentioned earlier from 2008 up to 2022. I won't go through much of this, but just to show you that, basically, that this is basically a very long-term study as well, that basically it was last updated in 2022. And what does this tell us, basically? So the Cochrane actually review examines 3 distinct clinical comparisons. And I want to walk through each carefully because the findings actually differ and the difference actually matters very clinically. Comparison 1, pharma plus IPC versus IPC alone. So adding pharmacological prophylaxis to IPC reduces both PE and DVT, but it does increase the bleeding risk. So it's relevant when you are considering escalating from mechanical only prophylaxis. Whereas comparison 2, this is the most directly applicable comparison for this room. Pharma plus IPC versus pharma alone. So the headline itself, right, adding IPC to an anticoagulated patient reduces DVT, high certainty evidence, and PE, of course, the evidence is low certainty with no increase in bleeding risk. Now, the comparison 3 is pharma plus IPC versus aspirin plus IPC. So results were basically similar between the two groups, suggesting that basically IPC is doing significant independent work regardless of which pharmacological agent actually accompanies it, basically. And in this data table that you see, this multimodal prophylaxis that you see here, this is the comparison in the data, basically pharma plus IPC versus IPC alone. When you add pharmacological prophylaxis on top of mechanical prophylaxis, what happens? So the symptomatic PE, as you can see in the top of the table, right, drops from 1.34% on IPC alone down to 0.65% with pharma added, so roughly half. And DVT incidence basically drops from 3.81% to 2.03%, actually, real reductions in thrombotic outcomes as well. But that's fair enough, we never doubt that pharma works actually. So, but look at the bleeding columns. So bleeding risk actually goes up from 0.95% on IPC alone up to 5.88% when you add pharma prophylaxis. So there's a major risk of bleeding basically. And of course, major bleeding rises from 0.34 to 2.21. Now, this is a clinically meaningful increase. So for your patients where IPC is the primary strategy, typically because anticoagulation is contraindicated, the decision to add a pharma agent carries a real bleeding cost. Now, that doesn't mean that you don't do it, but you do it with your eyes open and with a documented rationale that why you're doing it, it's perfectly fine. But just beware of the bleeding risk, basically. And in this slide here that we can see, right, it's basically a multimodal prophylaxis between pharma IPC versus pharma alone. So this is the comparison that actually matters most for your daily decision. You have a patient on enoxaparin, should you add IPC? So here what the data says here. So symptomatic PE, 1.84% on pharmacological prophylaxis, falling to 0.91 when IPC is added, essentially half. DVT incidence, 9.82 down to 5.48 with IPC added as well. Symptomatic DVT, 0.73 down to 0.59. Now, the bleeding question. So this is the critical safety finding. So bleeding risk on pharma alone was 7.45%. With IPC added, it was 6.55, numerically lower. Major bleeding, 1.1 on pharma alone versus 1.33 on IPC. So that difference was not statistically significant or clinically meaningful. But what I'm trying to tell you is that the bottom line from this table is that if you add IPC to your anticoagulated patients, it roughly halves the PE risk, reducing the DVT by over 40% and does not meaningfully increase the bleeding. So that is the case for a combination of prophylaxis in this slide, basically. So to close out the Cochrane study that we hear, CARCOS. So basically, what does it tell us? The evidence base covers your specialty, so it covers across all specialties. The conclusions are clear. Combining IPC with pharma prophylaxis compared to IPC alone reduces PE and DVT because the events rates are low, but the direction is consistent, basically. So combining IPC with pharma prophylaxis compared to pharma prophylaxis alone reduces DVT. Of course, there's a high certainty evidence, the strongest grade Cochrane actually awards, and reduces PE with low certainty evidence. So adding IPC to pharma prophylaxis actually does not increase the bleeding risk. And these findings actually align with what current guideline recommendations supporting combined modalities in hospitalized patients at risk of VTE. And what I want to say is that basically throughout the years, despite new iterations, there were 3 iterations of the same review, updates, consistent direction was made throughout. The direction of the paper and the outcome did not change throughout the years. The next paper I will talk to you about, moving to our second paper here. Basically, the second paper here is basically where CARCOS actually gives the broad systemic review, whereas IPC Super actually gives us a more RCT based, basically, in your most challenging patients. So this study, right, by Loberstoff and colleagues actually published in Annals of Surgery, basically a prospective randomized blind endpoint trial in patients at extremely high risk of VTE, so defined as Caprini score of 11 or above. Now, the study asked a few questions, basically. Does adjunctive IPC on top of standard prophylaxis actually reduce thrombotic outcomes in this population? A Caprini score of 11 plus is the high risk tier. So in an ICU context, basically, these patients are not rare. Prior VTE, active cancer, major surgery, all these, points accumulate up very quickly. So this study is basically built for your most complex patients. Yeah. And what do I see here? So what is the hypothesis of this study? So it basically combined IPC with standard preventive measures, basically above knee embolic stockings of 18 to 21 millimeters mercury, standard doses of heparin, would reduce post-operative VTE in incidence in extremely high-risk patients versus standard prophylaxis alone. So the design of it was basically a 2-center prospective randomized blind endpoint study. Basically, there were 407 patients enrolled. The primary endpoint was basically asymptomatic DVT reviewed by duplex ultrasound throughout during the hospital stay. or using ultrasound surveillance captures the events before they became clinically apparent, basically, the first sign of DVT. And the study design here. So basically the study design at a glance, I won't go through much details, but it was 2-center, 407 patients randomized to IPC adjunctive to your standard prophylaxis versus your standard prophylaxis alone, basically. And what does this IPC super actually tells us in terms of the primary outcome? So the results, and the numbers are pretty much striking here. So I will only go through the top figures because that's probably the most striking one and the more relevant ones. So asymptomatic venous thrombosis of the lower limbs, the primary endpoint that we see here, occurred in 1 out of 204 patients in the IPC group, 0.5% basically. In the control group, it was 34 out of 203, so that's 16.7%. The per protocol analysis was essentially identical, 0.5% in the IPC versus 17.2% in the control. The relative risk was 0.03, but to the point is that, what I'm trying to say here, very simply, is that patients already receiving heparin and anti-embolic stockings, which is the standard dual prophylaxis, the DVT occurred in 16.7% of those without IPC and 0.5% of those with IPC. So basically, adding IPC, right, actually reduced the event rate by a significant amount, probably 95% in relative terms. Now, that's not a marginal effect. That's basically a very huge impact for all of us. And standard dual prophylaxis was actually not enough for this population, and IPC was basically the difference here. And the IPC super conclusion, basically directly as published among patients with Caprini of 11 or above who received standard prophylaxis for VTE, adjunctive IPC resulted in significantly lower incidence of asymptomatic venous thrombosis. This is a level 1 evidence, RCT published in Annals of Surgery in precisely the kind of, basically the extreme risk patients that you manage in ICU. So standard prophylaxis alone wasn't sufficient for this population, and basically IPC closes the gap, basically, in this case. So that's the take home from this IPC super. The last study that I'll be going through here is basically the third paper here. So where Cochrane study was actually the most rigorous review, IPC super is the sharpest RCT. Ho and Tan actually gives us a more broad population level picture, sort of. Yeah. So it's an overview, right? This is basically a meta-analysis published in 2013. So there were 16,164 patients and 70 trials and 15 countries. So 2 central questions that was asked basically in this trial. Is IPC of the lower limbs effective in reducing VTE? And does combining pharma prophylaxis with IPC actually enhance that effectiveness? So 70 trials, 15 countries, this is the broadest general evidence base that we have for IPC. And of course, what does it tell us basically in terms of the summary, basically? 3 headlines findings. So first, what do they found basically? First, IPC was more effective than no IPC prophylaxis in reducing both DVT and PE. So that's the baseline effectiveness case. So basically it's trying to tell us IPC works. Secondly, IPC was also more effective than your stockings. So you have TAT stockings or compression stockings. So IPC is more effective in that, in reducing DVT. This is practically important for every ICU in the room, basically. If your unit defaults to a compression stocking where patient is being held on anticoagulation, this data says that basically IPC outperforms DVT on in terms of reduction. Yeah, outperforms the stockings in terms of DVT reduction. So third, basically what happens is that IPC appeared to be as effective as pharma thromboprophylaxis in reducing PE with a reduced risk of bleeding. So I'll be very honest and upfront as well. There was, of course, significant heterogeneity in the DVT comparison across the trials. So I wouldn't definitely call it equivalent across the board, basically. But what I'm trying to say is that the PE finding and the bleeding safety finding are consistent signals. And to be very honest, the honest read is that IPC is broadly PE comparable to pharma prophylaxis with a better bleeding safety. And the conclusion here that we have here is that basically combining pharma thromboprophylaxis with IPC was basically more effective than using IPC alone. So the combination is actually a multiplier and additive, basically. And into the numbers, what would we actually see here into the numbers, basically? So into the numbers, IPC versus no IPC prophylaxis or TEDs or your stockings. Across 40 trials, DVT was actually 7.3% with IPC versus 16.7% without. Across 26 trials, PE was 1.2% with IPC versus 2.8% without. So IPC basically roughly halves the both DVT and PE risk compared to no prophylaxis. So in 9 trials that directly compared IPC and stockings alone, IPC was basically associated with reduced risk of DVT, but not PE compared to TEDs. So the DVT advantage is clear, but your pulmonary embolism comparison didn't reach significance in those 9 trials. So IPC versus pharmacological prophylaxis. What happens is that IPC appeared as effective in reducing pulmonary embolism, your PEs, and was associated with a reduced risk of bleeding. However, as I mentioned, I want to be upfront about this, a significant heterogeneity in the DVT comparison between the trials actually existed. So when pulled together, IPC appears broadly as effective as pharma for DVT, but I will be overstating it, basically, if I say it's a definitive equivalent. So the PE equivalence and the bleeding advantages are basically the more reliable signals here that I can see. And adding pharma thromboprophylaxis to IPC, further reduces the DVT, but not PE, basically. So compared to IPC alone, basically. So mortality was also not significantly different between the groups in any comparison. And taken together, basically IPC works, it outperforms your stocking, and it appears PE comparable to your pharma prophylaxis with better safety profile because of the bleeding. And what I want to say is that it doesn't mean that you do not use the pharma prophylaxis at all. Basically, the combination here is basically more protective than either alone. And last but not least, I'm just going to be pretty quick about this. So basically, this is actually a study by Sinsa Kowat and colleagues published this prospective controlled trials in Thrombosis Journal in 2025. So it's a pretty new one in Thailand. So it's a risk-adapted VTE prophylaxis in Asians admitted to medical ICU. And their conclusion is basically VTE incidence among medically critically ill Asian patients was substantially high, and a risk-adapted approach using the Caprini score for VTE and HAS-BLED score for bleeding risk demonstrated both efficacy and safety. So effectively reducing VTE without a corresponding increase in bleeding complications here. So 2 practical implications. First, ICU-specific data confirming that the value of structured risk stratification, not blanket prophylaxis. Second, using tools that basically you already know. So your Caprini, your Wells score, HAS-BLED, to match prophylaxis intensity to the individual patient risk is evidence-based. So basically what he's trying to say is that, doesn't mean that, all patients you're going to put in on heparin, or doesn't mean all patients that you're going to put on IPC. So basically it really depends on the risk of the patients as well. And these guidelines here was actually published by the Indian Society of Critical Care Medicine, who published a consensus statement on VTE prevention in critical care unit in 2022. So two basically recommendations that I picked up from the guidelines actually that speak directly to the room here today. So recommendation 2.3.1, and I'll quote it directly. So in critically ill medical patients who cannot receive pharma VTE prophylaxis because of some contraindication, what the panel recommended actually use mechanical method of thromboprophylaxis. So whether it's IPC or your GCS stockings. So this actually was a strong recommendation from 8 out of 11 panelists. So the 3 panelists who gave conditional recommendation cited that, basically there's a limited number of clinical outcome trials in this specific subpopulation. So they basically 8 out of 11 actually gave very positive outcome. Just 3 of them gave conditional recommendations. There's no evidence of harm, just that they cited that there's a limited number of clinical outcome trials in this population. And recommendation 2.3.2 below there. So basically what you see here is basically the panel recommends the using IPC devices as the choice for mechanical thromboprophylaxis for VTE. So if IPC is not available, use GCS. Yeah. So again, also recommendation is given by the 8 panelists, and the other 3 decided to give conditional recommendations due to non-availability of clinical data outcomes, basically. Okay, so last but not least, just 3 takeaways here for everyone. You can probably forget my entire presentation, it's okay, but then just 3 takeaways for everyone here today. So 1, start early. So what does the data tells us? So VTE affects 4 to 15% of ICU patients, even with pharma prophylaxis in place. So when prophylaxis is omitted without a good reason, the mortality risk rises by 35%. And the data from 1.4 million ICU admissions says actually the conversation needs to start at admission. Secondly, consider adding IPC. So for your surgical trauma, higher risk patient already on anticoagulation, adding IPC actually half the PE risk and reduces the DVT risk without adding any meaningful bleeding risk. So it's basically do no harm. And the Cochrane review, a dedicated RCT in annals of surgery, a meta-analysis in circulation, basically all points to the same thing. So those papers that I presented earlier to everyone. And last but not least, when anticoagulation is not an option, IPC is not a compromise. It's not like second best. So it is guideline recommended first choice mechanical strategy. It outperforms your compression stockings on DVT reduction. And in the IPC super trials, in patients already on dual standard prophylaxis, IPC actually basically reduces the DVT from 16.7% to 0.5%. So those 3 positions are basically what I'm trying to tell you. The 3 takeaways here today are defensible from evidence standpoint, consistent with your current critical care guidelines, and easily actionable for every patient in your unit. So with that, thank you very much for my time. Thanks a lot.
Yeah, thank you, Dr. Cho, for very comprehensive presentation, and I think it's what we expect sometime in the ICU, that how to do prophylaxis or DVT from the patient. And we have the system in Vietnam. We can do both pharmacology prophylaxis and IPC. And then many patients with high risk in my ICU, we try both at the same time, IPC and pharma at the same time. And we do not have what you mentioned, like in Indian society guidelines, the GCS. It's complicated for us. So
it's okay. Yeah, fair enough, Dr. Sir. I think what you mentioned is a very, very fair point, because what I receive, right, a lot of times with different countries that share, is pharma superior, is IPC superior. It's not a question of which one is superior or which one is better. It really depends on your patient profile. If your patient is bleeding, if you have a high risk of bleeding, as you mentioned rightly, so why, take that sort of risk unless there's a documented rationale behind it. So thanks a lot. Dr. Sung.
Yeah, thank you. So now it's open for question from our audience, and please raise your hand, or you can speak directly to the speaker. And this is English club, so we welcome direct talk. So Dr. Hian, do you have any question for our speaker today?
Yeah, thank you, Dr. Choi and Dr. Chung Anh for very easy, interesting topic today. I have a question for the Dr. Choi. Do we need to exclude TVT before using IPC for VTE prophylaxis?
Sorry, could you repeat your question? It was breaking in the initial part. Yeah.
Do we need to exclude TVT before using the IPC for the TVT prophylaxis?
Sorry, I
Dr. Hian question. I think
Okay.
we always worry about if you have thrombus in the deep vein. If you use the compression, it can move the thrombus easily to go to the lungs. So that's why they scare. If you do compression, you need to make sure whether the patient have DVT or not.
I mean that because if the patient have the TVT, this may be dislodged and may travel to the lung and may cause PE if you use the IPC. I mean that in the protocol before using the IPC for TVT prophylaxis, do we need to scan for TVT at the beginning? I mean that. Do you understand, Dr. John?
Yeah, absolutely. I think rightly so, because prior to, the thing is that there is always a risk of thrombus being dislodged. So in the practice of defensive medicine and in the care of your patients, right, it's always rightly so that you need to ensure that like what Dr. Sun had mentioned as well, I echo it as well, that you need to ensure that there is no thrombus form in your deep veins basically prior to applying your applications as well.
Is the obligation? Is it for the older patient?
Sorry?
Is it compulsory for the older patient?
Yeah, because I think the practice here is that DVT is not taken very seriously, but the fact is that basically why you do it, because there is a lot of patients that come to you with undetected DVT, and it really depends on the risk profile of the patients. So when you do your scoring, right, your previous VT history, the age of the patient, is patient having any malignancy like cancer that predisposes to higher risk of VT and things like that. DVT and things like that. So this kind of risk scoring assessment, right, will tell you whether the patient have risk of having DVT or not, because that's how you actually do it at first. Because the thing is that we don't, at least in my opinion, we don't try to scan every patient. I'm not sure what Dr. Sun thoughts maybe is slightly different, because the fact is that resources are very scarce in every hospital. So it's very difficult to have patients being scanned, everyone for DVT and things like that, right? So basically you do a risk scoring assessment prior, and if the patient has the high risk, right, then only you do your scan beforehand. Yeah. Dr. Sun, if you have anything to add on?
Yeah, I agree with that. If you are, sometimes in the ICU, we have so busy to do many things. So they focus in the treatment, the patient, because the patient have so many problems. But prophylaxis is what recently more paid attention by the doctor. But I think that if you do scanning for all the patient in ICU, that very hard job and increase the burden for the staff. So I think I like the approach you recommend in high risk patient, and we see that the patient may have DVT, and if they have DVT, we need to treat the patient in advance. is in the patient with not DVT yet, maybe we do prophylaxis. So okay, so we take time for other question. Maybe here we see some of the expert in stroke unit. Here I see Dr. Hua. Dr. Hua, do you have any insight or recommendation from perspective of stroke patient? Dr. Hua, please.
Thank you, Dr. Sun, and thank you, Dr. Choi and Dr. Chuang for your presentation. I think this topic today is very kind of popular, and as a stroke center, we face with these risks every day with all the patients, and I think it's still a challenging for us to decide when we start to have a prophylaxis for stroke patient, especially for the patient with high risk of hemorrhage. For example, in the malignant of ischemic stroke with large vessel occlusion, or the patient with hemorrhagic stroke. However, in our stroke center, with the patient with the high NIS score, NIS score, with for example, they can the paralysis in one side of the body, and they cannot raise their hand with the NIS score from 6. We will, as Dr. Hiền already mentioned, all that patient, we will have a ultrasound to exclude any DVT before we decided to use ICP for that patient. And all the high risk patient will almost like we will use ICP for the patients. And of course, for the patient with much more high risk, for example, in the patient with subarachnoid hemorrhage, after intervention, we reduce the risk of hemorrhagic. We will decide to have prophylaxis for that patient, start to use anticoagulant for that high risk patient. However, in the patient with, for example, in the patient with the large vessel occlusion, and they have after thrombectomy or after intervention, or even they run out of time for intervention, decided to when we start to have prophylaxis for that kind of patient is really challenge, because they are in the high risk of hemorrhagic. So in that patient, we just we have to perform CT scan again 2 or 3 days after that, and we decided to have prophylaxis for that kind of patient. So I think in the stroke patient, all the stroke patient are the high risk of DVT. So we always have to think that we should have prophylaxis for the condition. And I think that ICP is one of the most method that is very easy, but it works very good and effectively, especially in the patient with the high risk immobility or with the hypercoagulable condition. So yeah, that's just my sharing from the stroke center. Thank you.
Yeah, thank you, Dr. Hua. And we see the one question for Dr. Cho. Do you routinely perform a follow-up ultrasound after patients are placed on IPC devices? Dr. Cho?
Now, a very good question. Now, basically, right, in very simple answer, no. Very simplistic, no. Routine follow-up ultrasound is not a standard practice after a patient is placed on IPC for DVT prophylaxis. Now, why do I say so? Now, it doesn't mean across the board, but then there are key points here. So, routine screening is basically the standard practice is not recommended on asymptomatic patients on IPC, right? So, when ultrasound is indicated, it's basically only if clinical symptoms usually develop. So, your leg swelling, your pain, your warm, your redness, then it warrants the ultrasound. So, the guideline approach basically, your DVT diagnosis should be guided by a clinical pretest probability. So your well scoring, not like a routine screening for everybody as well. So when to perform ultrasound, right, basically, in symptomatic patients, one, your leg swelling, pain, warm, your skin changes, redness, high pretest probability, so your well score more than 3 warrants compression ultrasound. Any negative, your initial ultrasound with positive D-dimer, you repeat usually in a week. This is the commonly used protocol. So they are, based on my experience, there are some clinical, there are some doctors who actually perform serial ultrasounds at 7 days, 10 days in an interval to assess the IPC efficacy. But this is not like a routine clinical practice as per se, basically. Yeah.
Yeah, I agree with that. Yes. Okay, thank you, Dr. Chow. And okay, is there any question from our members in here? I see many doctor from, but we have no name here. So you guys, if you have any questions, just raise your hand, or you just send them the question to our speaker today. Mr. Hui, do you have any comment?
Yes, one question for Dr. Chows. What is the most common reason for failure of VTE prophylaxis in hospitals?
I think one of the most common reason for sorry, your question was failure of VTE prophylaxis in hospital, right? Yeah, I think once of the most common failure is because, very simply, right, VTE is not something that it's not a specialty specific. So it's not, basically someone is taking responsibility for it in the hospital operation setting. So if you go to every hospital and you ask who is responsible for the VTE, it's not like an orthopedic specific, it's not an ICU specific, it's not the nurse specific. So it tends to be a very common oversight in terms of every hospital protocol that, people don't take note of it. Basically when the patient comes in, or, for example, the patient is pushed into the ICU, that's not the first thing that comes to your mind in terms of, to look at, your well scoring, whether to do the ultrasound, and then whether the patient has DVT or not. So it's really a very much an operational issue that we see here commonly. And this is not specific to Vietnamese, is what I see across the entire APAC region. That when I speak with the doctors and things like that, with hospitals and things like that, this is very, very common practice that, basically no one is sort of like, managing it, and no one is basically heading it, basically, in terms of, the operation side of things. So that's one of the main failures of, why VT prophylaxis is not being actively taken. And two, secondly, it's also partly because of the knowledge base, because, there are conflicting, I have no doubt about it, there are conflicting clinical trials that we see in different places. Basically, I think like what I presented earlier, I do get people talking, the pharma prophylaxis is superior to IPC, and basically then what do we put the patient on and things like that. So in terms of, knowledge wise, I think it's still very much lacking in every part of the region, because it's not really a subject base that's being taken seriously by anyone in the hospital setting. So that's also the second part that I do see commonly.
Yeah, okay, thank you very much. And any question?